Greetings. I'm Amrou Sarraj, and it's a pleasure to present at the MENA conference on new frontiers in thrombectomy and expanding the indications for a new population. So we all know that endovascular thrombectomy is safe and efficacious, but that was in certain populations that were studied extensively in randomized clinical trials in patients with anterior circulation large vessel occlusion in the ICNM1 with moderate to severe stroke with a stroke severity of 6 or more and a favorable imaging profiles. Those are the patients with aspects of 6 or more and a small core infarct on perfusion. But there are areas that were not studied in the prior trials. They focused on those certain populations that I mentioned, so patients with milder severity strokes or mild deficits, as it's called, an IH of 0 to 5 with an anterior circulation large vessel occlusion, and there are these patients with large core and aspects of less than 6 and a core infarct, large core infarct and perfusion of 50 cc or more that were not studied in the prior trials. And these are the two areas that we will tackle during the next 20 minutes or so. We'll start with those with mild neurological deficits due to large vessel occlusion. So we start with saying this is an important population, and 66% of all stroke patients would have a mild deficit, and 10% of those would be due to large vessel occlusion. And based on your resource, it's 10 to 20% where these mild neurological deficits may get worse, may lose their collaterals, may progress to higher NIH. So it's important to know what to do with them. And we don't have evidence on the efficacy and safety on these patients because they were excluded from the prior clinical trials. Only Mr. Clean allowed patients with stroke scale of less than 6, and there was limited number of patients in the Hermes meta-analysis. And this is looking at the Hermes stratification of outcome by stroke severity. And you don't see even a category of less than 6 because, as I said, limited number of patients. But let's even go with the stratification of 10 or less versus 11 to 15 versus 16, 20, and 20 and more. And you see that, and I'm focusing on the medical management, you see that as stroke severity decreases, the likelihood of good outcome with medical management increases. Even with a stroke scale of 10 or less, you have 55% of the patients with medical management without thrombectomy did well. So that's the question of how much more can thrombectomy do? We can imagine that the percentage of good outcome rate with less than 6 will be even higher than the 55%. And this is the forest plot from the Hermes meta-analysis, and you see the population of less than 10 crossed the midline. This favors thrombectomy, this favors medical management. Across the midline, there is no statistical significance. We still treat patients with 6 to 10, but that raises further question marks about treating patients with stroke severity less than 6. The current guidelines, the American guidelines and the European guidelines, tells you that the benefit is uncertain, which is true, and that calls for additional randomized trials. And that's what really would move the needle. The European guidelines tells you that these patients actually should be enrolled in clinical trials. Kudos to them for encouraging that. And those who are not eligible to trials are reasonable to be treated if their deficits appear to be disabling, and they are giving examples of a significant motor deficit, aphasia, or hemianopsia, which is the eloquent area, so to speak. And in the case of neurological worsening, which we talked about, that can happen up to 20%. But whenever you are facing a patient with a large vessel occlusion and mild deficit, and any patients really, you calculate the risk and benefit ratio. When there is clear evidence of the risk benefit ratio, as I mentioned in the other populations that were tested in the trials, then this is a slam dunk. But here, you're facing patients with mild neurological deficit. Why would I intervene? They are doing very well. But they have, and also if I intervene, I may make them worse. That if there's dissection or bleeding, the patient's worsening, the likelihood of getting worse when you have mild deficits may be significant and may not be justifiable to do the procedure. But if I leave them alone, they may lose their collaterals, they may get worse, and thrombectomy may still be reasonable, as I mentioned in these patients. Even the guidelines mentioned that when we don't have randomized evidence, we look at what evidence we have, and there are contrasting results, really. There are studies that showed potential benefit, and there are studies that did not show potential benefit. And actually, the latter is more than the former. And we'll go through a few of these studies to see how that looked. And this is a cohort study from 6 centers in the United States and Spain from us that we published in Stroke 3 years ago, where we looked at thrombectomy versus medical management, retrospective, non-randomized, and we found no difference with the good outcome, 67% versus 64%, with the excellent outcomes, 0 to 1 MRS, 55% versus 54%, no statistical significance. And the symptomatic hemorrhage rate was higher with thrombectomy. The mortality rate was higher as well. This is a meta-analysis that took our study and other studies into consideration. And overall, you see the forest plot showing no benefit. I mean, again, these are retrospective studies, but no association with thrombectomy of improving the outcome in patients with large occlusion and mild deficits overall, based on the available evidence from retrospective studies. But there are studies that showed potential benefit. This is a study from collaborative effort from the United States and European effort that looked at patients who received direct thrombectomy and those who received rescue thrombectomy after they worsened. And you see that those who received direct thrombectomy did better. So maybe when the patient worsens and then you go to thrombectomy, you're not getting the same outcome if you get thrombectomy directly. And this argues for taking them to thrombectomy directly. But why do we have different results? Well, maybe there are different populations. This is not a homogeneous population. It's rather heterogeneous. The patient's collaterals, the patient perfusion imaging status, all of that can differ. And there are different approaches in the studies. Some of these studies looked at immediate versus rescue thrombectomy. Some of them looked at thrombectomy overall versus medical management. And the inclusion of patients, some distal versus proximal occlusions. And there is definitely different association between thrombectomy and outcomes based on these population. But how may we improve this risk-benefit ratio calculation and better select the patients? Maybe just like similar to what the European guidelines told you, maybe identifying patients who may worsen with medical management, as I mentioned, early neurological deterioration, anywhere between 10 to 20% in different studies. Look at the collateral status, look at the perfusion images, how it looks with the delay in the blood flow, and I will show some imaging on that. And additional consideration: where's the clot? Is it proximal versus distal? How long is the clot and the clot burden? And a lot of us challenge these patients in the emergency room and look at their stability with reducing the blood pressure, maybe walking them and seeing if they could walk, of course, and seeing if they would deteriorate or not, challenging them, so to speak. And looking at the proximal versus distal, this is from our study. And remember, overall, there was no association with better outcomes with thrombectomy. But when we looked at the ICA and M1, thrombectomy was associated with better outcomes, increased in mortality, and this is important in calculating the risk-benefit ratio, but overall you see improvement with thrombectomy. You look at the proximal occlusion versus the distal occlusion, medical management patient did very well. 80% good outcome, even better than thrombectomy, with better safety profile. And this is a study from France that looked at the same question, bridging with thrombectomy versus thrombolysis only, and you see that patients with ICAM1 did better with thrombectomy, while those with M2s did better with thrombolysis alone, and this is consistent with our results. How about fluctuating patients? As I mentioned, the study from the United States and Germany and Europe showed that when you intervene early on, you achieve better outcomes with thrombectomy rather than those who worsen and have a risky thrombectomy. Look at the collateral status. I mean, you can look at a simple CTA and you see this patient with an M1 occlusion on the right does not have very good collateral, so maybe a candidate for deterioration versus better collateralization flow here, and this patient may do well with medical management. You can look at the HIR, the ratio between the 10 seconds delay to 6 seconds delay on perfusion images. And when you see a large area of 10 seconds delay, that means you do not have good collateralization and a poor HIR versus a smaller area of 10 seconds delay and better HIR, that those patients may fare well with medical management. The additional consideration on how long is the clot, and French reported on that, and using the clot burden score, the larger the clot, the most likely the patient would worsen, and you may consider intervening. We do that till there is evidence from randomized trials. There are ongoing randomized trials. There is a United States one, the ENDOLO, that is looking at this population with an ICM1 occlusion or a large M2 with small core volume, stroke scale of 0 to 5, and randomizing them within 8 hours to thrombectomy versus medical management. There was an extremist that randomizing up to 24 hours thrombectomy versus medical management patients with the aspects, mild deficits, and a large vessel occlusion in the anterior circulation. So what do we know so far is that overall, we do not have randomized evidence of benefit. There is potential benefit in patients with proximal occlusions, longer clots from retrospective data. We have evidence that patients may neurologically deteriorate if not intervening, and those who deteriorate will have worse outcomes than the ones intervening on directly, which clearly call for randomized evidence from thrombectomy, especially those patients with poor collaterals on the CTA or perfusion are more likely to worsen. So for this population, we conclude that we have limited evidence from randomized trials. The randomized trials do not focus on enrolling these patients. There are retrospective cohort studies with contrasting results. There are RCTs going. I sure hope that these RCTs deliver the evidence, conclusive evidence that we want. But keep in mind, when medical management patients do well without intervening, you're talking about 70 and 80% good outcome rate. You have to have a very strong treatment effect to show improvement with thrombectomy and justify doing thrombectomy in these patients. And these patients are not as common as the moderate to severe strokes with large vessel occlusion. So I hope the trials get good enrollment quickly. But this is a concern on what could happen. So what should you do in meantime? Definitely consider thrombectomy in disabling strokes. You're not treating a number, you're treating a patient. If somebody comes in and they can't move their arm, they can't move their leg, but there's no other deficits, and their stroke scale is still within the 0 to 5, you may want to consider thrombectomy, especially in the eloquent areas. Even if you have somebody with significant aphasia, this will be disabling to them without reperfusion. Take the collaterals and perfusion into consideration. Large perfusion deficits and prolonged delay on advanced imaging maybe an indication of neurological worsening, and you should intervene and monitor closely. Look at these patients. If they worsen, take them to thrombectomy as soon as possible. And when you have the opportunity, if you are in a randomized trial, please enroll these patients so we have the conclusive evidence into that. So that's for the mild strokes, and hopefully this frontier will come with fruitful evidence on intervening on these patients and thrombectomy potential benefit and safety. Shifting gears to a totally different population. Those are the patients with large vessel occlusion and large ischemic infarct, whether on CT or perfusion. And as we know, the evidence that we have now is in a totally different population. Those with good aspect, small cores on perfusion. This is a patient with an MCAM1 occlusion that has no ischemic changes on CT, no core on infarct, and large area of penumbra. Those are the patients that were really enrolled in the early and late window trials, while the patients with large core, which you see totally different picture, low aspects, large hypodensity, large core on perfusion, those patients were largely excluded, and we don't have evidence on them. And going back to the risk and benefit ratio, you look at this and you discuss with your interventionalist, or if you are the interventionalist, well, there is a large infarction already. And there is a risk associated with the reperfusion in those large areas, and could be higher than reperfusing without early ischemic changes, and those patients may bleed. But if you don't intervene, the patients here, as an example, has a larger Tmax, more than 6 area, and delayed flow, so they will probably continue to infarct. Without intervening, will have a higher risk of herniation, higher risk of death. So maybe thrombectomy can help you avoiding that. Maybe it can help you more with improving the outcome, even to functional independence. We looked at this specific question in the SELECT prospective cohort study, and SELECT was a prospective cohort, non-randomized study. We are doing the randomized phase in SELECT 2 currently. And within SELECT, we had 105 patients with large core on CT or CTB that are with aspects of less than 5 or less, and core infarct of 50 cc or more. And in a randomized fashion, we pre-specified those unfavorable profiles to the investigators, and we looked at them, and you see non-randomized, so selection biases are probably there. The younger, the healthier patients, the smaller cores were treated with thrombectomy versus the ones who were not treated and left medical management. Still, we had 105 patients, 62 received thrombectomy, 43 received medical management. And see, the good outcome rate is around 30%, 31% with thrombectomy versus 13% with medical management. So you are not seeing the 50 and 60% good outcome rate that you see with small cores, but the absolute difference from medical management is there. It's around 18 to 20%, which is a significant number, and this translated to statistical significance on the functional independence, the 0 to 2, and the shift in overall shifting to patients to better outcomes with thrombectomy. The risk and the increasing the mortality was not there. Actually, mortality decreased with thrombectomy from 42% with medical management to 29% with thrombectomy. And the risk of symptomatic hemorrhage, while symptomatic hemorrhages were higher with thrombectomy, but this did not translate to statistical significance. And keep in mind, you're talking about 13% out of 62 patients, so 7 or 8 patients who had symptomatic hemorrhage. So not very low, but not a high number that we are worried about. And this translated to smaller final infarct, almost cut in half with thrombectomy, and smaller infarct growth from the initial images to the follow-up images, which is of significance to avoiding herniation and hemicraniectomy. So looking at it, if you're treating by CT only, you see that thrombectomy with outcomes rate were 35% versus 18%. And the mortality and the very poor outcome was reduced with thrombectomy, and this almost translated to statistical significance. Keep in mind, you have only 70 patients here, so it's very hard to show statistical significance with that, but showing clear signal of potential benefit with good safety profile. And when you look at large quorum perfusion, you see even more difference between thrombectomy and medical management. Whether you choose it or CT or perfusion, that's a totally different question. And what does perfusion add with identifying the core, identifying the mismatch, the healing treatment effect? All of these are things that we will be exploring in the SELECT-2 trial when the trial results come out. But clear signal, even with 74 patients, shift towards better outcome with good safety profile. And then I mentioned, do you identify large core on CT or CTP? Two imaging modalities measure different things, actually. CT measure the hypodensity by the aspect score. It's a semi-quantitative ordinal measurement, while perfusion that measures the blood flow and volume and velocity, and it's a quantitative measurement. So I'll present two patients to you with the same aspect score with the left MTA. Both will have an aspect of 4. The first one had a core infarct of 92 cc, and the second one had a core infarct of 174 cc's. If CT perfusion is adding additional value to prognostication and patient selection, then these two patients will not respond the same to thrombectomy in terms of the good outcome and the safety. And this is one of the things that we're looking at in SELECT-2, and this is the difference between SELECT-2 and other trials, as it looks at both CT and perfusion, while the other trials look at aspects only. So hopefully will inform the field on this. And this is the SELECT-2 trial, which is ongoing currently. And we are enrolling patients with an aspects of 3 to 5 and a core volume of 50 cc or more on CT or perfusion, looking at the safety and efficacy of thrombectomy. And we are also looking at the heterogeneity of the treatment. This population with large core on CT, not on CTP, and vice versa, is not to be ignored. It's a significant number of patients. And when you have two imaging modalities, you want to know if you should treat your patient or not. And if you have perfusion, you want to know how far you can go. Is it 150 cc? Is it 200? Is there no upper limit? And the importance of that is not just doing a procedure, but the safety of the procedure and the potential efficacy. Even if you treat all of these patients, it's important to prognosticate and see how they will do. This is a prospective randomized multi-center open label phase 3 trial that's ongoing right now. We have up to 30 centers enrolling patients in the United States, Canada, Spain, Australia, and New Zealand. Our target is 560 patients, and we're looking at shift because of the outcome, because MRS 0 to 2 may not be of higher rates in this population. Just think about it, large vessel occlusion and large core infarct, and having an MRS of 3 isn't a poor outcome. Actually, it's a good outcome in patients with large vessel occlusion and a large core. So the shift is better equipped to capture all the changes across the MRS. That's why our primary analysis is the shift. These are our enrollment centers in the United States, Canada, and Spain, and Australia, and New Zealand. We're going very well because we exceeded 200 patients. We'll see where we're at, and there are other trials that's enrolling, as I mentioned, Tesla based on aspect, and extremist last day based on aspect, as well tension based on aspects. There is also a Chinese and a Japanese trial. The Chinese trial takes CT and perfusion into consideration. Hopefully all of these trials help informing the field on that. And I hope that these frontiers come to fruition. And in a few years, we may be talking about efficacy and safety in large core, and efficacy and safety in patients with mild deficits. So far, thrombectomy has been a revolutionary treatment. Hopefully it extends to help more patients in the near future. thank you so much for having me, and hope you all enjoy the conference.